Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. All right, hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Doug Maynard, your host for the next approximately 1 hour. And Spark Live is where we gather each Wednesday to curate and convene and showcase excellence and innovation from across the child and youth healthcare community, with our goal to spark conversation, ideas, and action. And since we are live, I do want to remind everyone that you do have the opportunity to ask questions during this session. We may check for questions at any time, so please type your questions in as you think of them. Don't feel you need to wait until the end of the presentation to type those in. And always feel free to share any of your thoughts on Twitter related to this webinar, and be sure to tag us at Child Health Can. And so today we're going to be talking about patients' perceptions of physician wellness and its links to patient care. And this is from a qualitative study. And our presenter today will be sharing with us some of her research from this study regarding 20 patients on physician wellness. And the study did focus on physicians and patients in the adults. It focused specifically on physicians as well as patients in the adult setting. But we are certainly interested in hearing your comments and questions from the audience regarding how this might be the same or maybe even different. Some of the unique aspects of the pediatric setting that may, impact what we hear today, or even when we're looking at healthcare providers other than physicians. Does this look the same or different? So without any further ado, it's my pleasure to introduce today's presenter, Alicia Polachek. Alicia is a senior research associate at the W21C Research and Innovation Center within the University of Calgary's Cumming School of Medicine. And Alicia holds a Master's of Arts degree in Sociology from the University of Calgary and has expertise in worker well-being along with qualitative and mixed methods research. And Alicia manages the physician wellness portfolio at W21C and works closely with Dr. Jane Lemaire on numerous projects examining physician wellness. So without any further ado, it's my pleasure to hand the virtual podium over to Alicia Polachek.
Thank you very much. I'm very pleased to be here today on behalf of our study team. You can see it listed there on the right-hand side of the screen, and I get the pleasure of joining you today to tell you about our study. As you heard, it does focus on adult patients and their perceptions, but I definitely do welcome discussion and consideration of how it might be similar or different, as we heard, in the pediatric population and in different groups, and I do have a slide kind of addressing that closer to the end of the presentation. But we're quite excited about some of the findings. It is quite an innovative project. So a little bit of a background on physician wellness. We know that it's a really important topic, and it's been receiving increasing attention over the last several decades. We know that physicians are at a higher risk than the general population for serious health consequences for things such as burnout, substance abuse, depression, and suicide, largely in part due to their work and the expectations that are placed on them. Physician wellness impacts the individual physicians who are experiencing unwellness, but we also know that it impacts healthcare delivery and healthcare systems. So it really is important as it can affect everyone. For example, we know that physician stress, burnout, and job dissatisfaction can harm the doctor-patient interactions and relationships, and we know that it can result in suboptimal patient care. We also know that physicians' health behaviors can influence how they counsel their patients, and research shows that when physicians use preventive health practices, such as undergoing mammography, colorectal cancer screening, and vaccinations, that their patients are also more likely to follow those preventive measures. And so physicians really do have a powerful public health influence by setting an example for patients, and what they do in their own health and wellness is important for others. With the mounting evidence regarding the prevalence and impacts of unwell physicians, physician wellness has even been proposed as a missing quality indicator for healthcare systems. But it's really interesting to note that physicians have often reported feeling that caring for their own wellness is actually at odds with their professionalism, and that it's their duty to care for patients above and beyond everything else, including taking care of themselves. So we often hear examples of physicians working while they're ill, and some have identified beliefs and behaviors or beliefs that behaviors such as eating at work are unprofessional, and that patients may actually consider them to be unprofessional and view them differently if they're seen taking care of themselves essentially at work. And so we know that the medical profession may hold these views, but we're really not sure if patients do hold those views themselves, or if that's a bit of a misconception on the part of healthcare providers. So with that background, we know that there's quite a broad body of literature around physician wellness now, but very little is known about how patients actually view physician wellness and how they see it impacting or being related to their care. We know that some research has happened in this space, but it's focused particularly on physician body weight. So there was one study by an author named Poole that demonstrated that patients can hold weight biases, where patients of a normal weight may be less trusting or less likely to follow the medical advice from an overweight physician. And they also reported that they're more likely to change providers if their physician was overweight. Beyond that one study, though, there's been very limited research in this space considering patients' perceptions. And we recognize that physician wellness goes well beyond body weight, and that it's important to have a broader understanding of how patients view physician wellness, in particular to explore how they think it might be related to their feelings about their care as well, realizing that that's an important metric. And it's important to recognize that physician wellness may not be as easily observable or identifiable as things such as weight. So there's a variety of reasons for that. One being things like mental or emotional well-being, for example, are often much harder to observe than some kind of a physical condition or appearance. And we also know that sometimes patients, when they're visiting a physician, they're unwell themselves, and so they're often focused on their own situation, their own context, and may not realize what's going on with the physician. Against that backdrop, then, we decided to undertake a study called Understanding How Patients Perceive Physician Wellness and Its Links to Patient Care. It was recently published in PLOS One just at the beginning of 2018, so just about a year ago now. And it actually received the 2018 Stanford Medicine WellMD Center Physician Wellbeing Article Award, recognizing its contribution to advancing the field of physician wellness. This is one of, or the only that we are aware of, study looking at patients' perceptions of the topic. And so it's really quite a new avenue for research and something that has not been adequately explored. And so we were recognized for that contribution. A little more in depth than our study aim was really to explore patients' perspectives and perceptions on physician wellness and how they see physician wellness linking to their care. We did this through a qualitative study, and we used a constructivist orientation. We realized that patients might have diverse perspectives and understandings based on their unique experiences and their interactions, and so we wanted to allow those types of ideas and unique perceptions to emerge from the study. We didn't want to determine questions in predetermined categories and ask people to fit themselves into those boxes. We wanted to hear what they really felt and what they wanted to bring forward to the research. And as I'll mention later, that actually allowed us to identify some interesting things we hadn't thought of before. We did focus on patients over the age of 18. We recruited them from outpatient settings here in Calgary, Alberta. And we wanted to ensure, part of why we did that was to ensure that the participants had a fairly robust exposure to the healthcare system. So we wanted people who interacted with physicians, not people who had very limited interactions with the healthcare system. We hung posters at an urgent care center here in Calgary, as well as an outpatient diagnostic and treatment center, and all locations of our citywide laboratory collection service. We also had members of our research team actually go on site and set up a study information booth at the urgent care center on 3 separate locations. Interested patients then could approach us either at the booth or reach out via the poster information and ask for more information about the study. And if they were interested, they could participate in either an in-person interview at the urgent care center, or we could arrange a telephone interview for them. In total, we interviewed 20 participants. They were all one-on-one interviews, and we conducted 7 of them in person and the other 13 via telephone. The interviews lasted an average of approximately 46 minutes, and all interviews were digitally recorded to facilitate analysis, and they were transcribed verbatim. In terms of the interview questions, you can see this isn't the complete interview guide. This is the kind of the higher level questions that we initially asked. These questions were asked of all 20 participants, and then we also used a series of probes and prompts as needed to follow up on different ideas that came from the participants, to explore new ideas, and to elicit additional examples and descriptions, more detail around that. We encouraged participants to draw on their personal experiences, examples from friends or from family that they had heard about, and general perceptions. We didn't ask them to specifically evaluate their family physician, for example, or other specific physicians that they had interacted with. We wanted to get a broader sense. And this really ensured that participants could draw on a variety of examples and describe their perceptions more broadly without just focusing on an individual provider. Once we got all of our data, we analyzed the interviews using inductive thematic analysis. So 2 authors, myself and one of the medical trainees on the team, independently read through the transcripts, and then we identified initial codes that emerged from the data. So we didn't go in with a priori categorizations and look for examples of them. We really let the data speak and then created codes based on what was coming out of the data. Once we had our initial codes, we met together to discuss them and to reconcile any discrepancies and kind of come to consensus on what we were seeing from the data. Once all of the data was coded, we then grouped similar codes into themes and proceeded to group similar themes into broader overarching themes. And then we had a final level of interpretation where we included the full study team and we ended up generating 3 overarching premises regarding how patients may perceive physician wellness and how it links to their care. So quite an iterative, collaborative approach to that analysis. In terms of our sample demographics, most of our participants were female, most were married or living in a common law relationship, and most had children. The average age was 57 years old, but we had quite a broad range of ages, ranging from 25 to 92. Most participants also had at least some post-secondary training, and a lot of them were retired or semi-retired, as reflective of the somewhat older age group that we interviewed. With regard to their health, we also asked them how their mental and emotional and their physical health compared to others their age. And most participants indicated that they had good or very good health for both physical and mental or emotional compared to others their age. We also asked participants how often they interacted with the healthcare system, and most of them interacted at least monthly. Quite a few also every 2 to 3 months or weekly, so fairly consistent or frequent users of the healthcare system. And as I mentioned, we identified 3 overarching premises. These are our highest level themes that came out of the data and really kind of describe what we found in the data overall. So the first one is that patients do notice cues in physicians that they are interpreting as signs of wellness or unwellness. We know that these perceptions or interpretations may or may not be accurate. So for example, a patient may perceive that a physician is unwell. If you ask that physician, they may feel differently, and more subjective measures of wellness may indicate that they're not unwell, but patients are taking these cues to indicate some level of wellness or unwellness. And I think in and of itself, that interpretation is important, whether or not it's accurate, because it is, as we'll see in the second premise, it is influencing their feelings about their care, how they interact with physicians, and the view about the quality of the care that they're receiving. The third premise is that patients also perceive a bidirectional link between physician wellness and patient care. They acknowledge that physician wellness impacts the care that they're delivering to patients. But really interestingly, they also talked about how physician wellness is impacted by the care that they provide to patients. So we didn't go into the study with any hypotheses. It really was very exploratory and designed to identify hypotheses. But we anticipated that when we wrote the questions, we anticipated that participants would talk about how if a physician is well or unwell, it impacts the care that they're able to deliver to their patients. And we were quite surprised by, we definitely heard that, but we were quite surprised by the amount of recognition that patients also had in terms of how providing care to patients can actually have an impact on physicians and often impacting their wellness. It can be quite a demanding job, and patients really did recognize that and saw that bidirectional link. So over the next few slides, we'll delve a little more deeply into each of these premises. I'll give you some examples of some quotes that really highlight or illustrate those examples as well. So for the first one, patients really do interpret or recognize cues that they interpret as signs of wellness or unwellness. We know that it can be difficult to discern physician wellness, but despite that, most patients are picking up on cues and interpreting them as signs of wellness or unwellness. These cues can be somewhat easily observable, such as physical appearance, demeanor, work pace, signs of stress, or they may be a more general impression of physician wellness. For example, some participants described an ability to quote unquote sense an intangible energy, particularly when they had been interacting with that doctor over some time and had a fairly well-developed relationship with them, where they could observe changes in a physician's emotional stability, weight, or demeanor between visits, and a change in the consistency. Here are a couple of quotes that illustrate those themes, and these are just a sample of many possible quotes that we could have drawn upon. The first one talks about recognizing that a physician was totally run off their feet. They looked totally stressed out and not being able to keep cases straight. Those were some of the cues that they interpreted as signs of unwellness. The second quote there talks about that consistency and changes over time, how a physician started off fairly trim. In the end, she had put on an extra 100 pounds, and it made the patient really feel that perhaps she wasn't eating and taking care of herself properly. She also started out more relaxed, and near the end, she seemed to be more tense, always looking tired and stressed. And so you can see there some of the cues that people interpreted as signs of unwellness in terms of looking stressed, looking tired, looking like they perhaps weren't eating as well as they should. The second premise is that patients form judgments based on those cues that they're noticing, and these judgments have a series of impacts on them. One of the first impacts is that it changes how they view their care. And so the results really showed that overall, patients who judge physicians as unwell tend to have more negative views of the care that they're receiving. And so participants described unwell physicians as less connected within the medical community and thus limited in making appropriate referrals to specialists or other providers. They also reported them to be less competent and more likely to make errors. And they reported them to be less appropriate with patients or staff, more disorganized, and more likely to place added responsibilities on the patients themselves to either limit their problem list or to self-diagnose. So asking them, well, what do you think's wrong with you? What do you think's most important to talk about? Those kinds of examples. Again, we have a couple of quotes to illustrate those. They talked about in the first one how physicians that they perceived to be unwell seemed more withdrawn, and they were less confident that that doctor had access to appropriate surgeons or dietitians in this example because they hadn't nurtured those connections. They were just too withdrawn and not building those relationships with other providers. In the second quote, they also talk about the visits being really quick and short and the patient feeling as though they had to tell the physician everything. The physician wouldn't follow up. The physician wouldn't suggest courses of action to take. The patient really felt that they were driving that encounter, and they perceived that as a sign of unwellness, and it impacted how they viewed the care they were receiving. Relatedly, participants also described feeling less comfortable with and less trusting of physicians that they perceived to be unwell. Those feelings of trust and confidence could even be threatened to the point where where patients may go to a different physician, particularly if they didn't feel that they were treated as a whole person and that they weren't engaged in their care in a compassionate and empathetic way. Again, there's a couple of quotes here illustrating these examples. They talked about how unwell physicians made them feel uncomfortable, felt as though the physicians weren't taking care of themselves, and if they weren't taking care of themselves, how could they be fully present with the patient and take care of them? So they talk about worrying about them a little bit, which we'll hear a little more about on the next slide. In the second example, there's another case where a patient talked about the physician really just staring at the computer, not interacting with the patient. The doctor didn't ask the patient about any concerns or questions and really didn't acknowledge the patient as a person, a whole person who's there in the room with them. Patients also described questioning and being unwilling to follow the recommendations of unwell physicians. They talked about altering their behavior during appointments. For example, limiting their discussion with a physician. So if they had initially gone into an appointment with 2 issues or a few symptoms that they wanted to talk about, they really limited that list because they didn't want to overburden them any further. And they talked about having compassion and concern for unwell physicians, where they did actually alter their behaviors in order to not further overwhelm or stress them out. There's a couple of quotes here. In the first one, the patient really says, I start worrying about them, and even to the point where they may send a card or a gift because they were quite worried about the physician. And again, that was especially the case if they had a relationship over some time. In the second quote, that's the example I was alluding to, where maybe there was 3 things that they wanted to talk to their doctor about, but they decided to really limit it to only what they deemed the most important and leave the other 2 for another visit because they didn't want to stress out the doctor. And although, on some level this may seem unimportant, but patients often aren't in the place to know perhaps what's the most important thing to bring up, and so it could actually have quite serious implications on their care. The third premise then, as we mentioned, is that patients perceive this bidirectional link between physician wellness and patient care. So participants really described physicians as humans. They talked about them with having needs in order to take care of their own wellness. They talked about the expectations, both on a patient level and a societal level, that physicians face and how that can actually challenge their ability to maintain their wellness. They recognize that some of those expectations may actually be unrealistic and unachievable for physicians. Participants also highlighted the need for physicians to implement the strategies that they advise for their patients. So that idea of following their own advice and making sure that they're taking care of themselves. They talked about the need for physicians to also role model those behaviors and let their patients know what they're doing in order to take care of themselves. They talked about how physicians should set boundaries around their work, that physicians need to manage their stress, and that physicians need to lead a healthy and a balanced life. They need to set some of those boundaries and really be engaged in a variety of things, not just focused on their work. Interestingly, the participants also described how physicians' wellness can be impacted by the care that they provide as they work within a challenging healthcare system with high work demands and high expectations. There's often poor access to resources, either for delivering patient care or for supporting the physicians in their wellness, and that there's often a lack of patient accountability for self-care. So this idea that a lot of patients go to a physician and they expect the doctor to really just to heal them, to fix them, and that they don't need to take actions themselves to help improve their health. And that all of those things can take a toll on the physician. A couple of quotes here that talk about that. So the first one identifies the long hours that they have on their shifts often, and how those kinds of expectations for those long demanding work hours can actually be a systematic failure. So acknowledging how that system can impact the physician and how that needs to be perhaps adjusted. The second quote there talks about how that idea that doctors are people too. We often put them on this pedestal, but they are just people. And because of that, they have wellness needs and their mental health can't be perfect all of the time. Physical health probably as well, but this quote did focus specifically on mental health. They recognized that it was really quite impossible for physicians to be well 100% of the time, and that because of this, patients also need to take some ownership for things that happen, do some research, or be an active participant in their care. And finally, with this, participants really highlighted that cyclical relationship between physician wellness and patient care. So they talked a lot about how an unwell doctor delivers less or worse care, I suppose. This idea that unwell doctors can put patients at risk in some cases, often making more errors. But they also talked about the other side of it, where patient care impacts physician wellness. So putting patients first all of the time can really limit a doctor's ability to take care of themselves, which can have implications on their physician wellness. And so you can see that kind of almost a vicious circle, right? Where physician wellness, if a physician's unwell, it impacts the patient care, and that patient care also feeds back and impacts the physician wellness. And so it's not just a simple, straightforward relationship. The participants we spoke with really identified how it was quite a complex relationship between those two factors. This was also evident through a few quotes again. So the first example talks about comparing it to a flight, essentially, where they say you need to put your oxygen mask on first if there's a plane where the oxygen masks deploy. And if a doctor isn't looking after their own wellness, then it's not really reasonable to expect that they're delivering the standard of care that the patient may need. So that idea that if they're not well, they can't take care of their patients as well as they could if they were taking care of themselves first. And the second quote talks about how the expectations that patients often have, where they have taken this oath to do the best that they can, but it can be overwhelming or frustrating and energy sucking to take care of some of those patients who just say, help me, help me, help me, and aren't willing to take a bit of the onus on themselves to do what they can as well to help improve their health. And we recognize that that's a balance as well, right? We don't, as a few of the other patients had talked about earlier on, they don't want to feel that the doctor's placing all of the responsibility on them to the point where the doctor isn't kind of fulfilling their role, but it really should be more of a collaborative effort, according to the patients that we spoke with, where the doctor is providing that guidance, those recommendations, asking what's going on, but the patients are also being involved and taking some ownership of what they can also do to help that interaction and not just expecting the physician to do it on their own. So in terms of a couple of take-home messages, if we kind of zoom back out from those details and pull it all together, there's a number of key messages that I think are just worth reiterating. First is that patients really do notice things about their doctors. And based on what they notice, they are making judgments. And those judgments can have important impacts on the doctor-patient encounter and the relationship in terms of how they feel about it, how they perceive the quality of care, and how they're actually interacting in those encounters. So quite important impacts potentially. We also saw evidence of this, what we've called reverse caring, where patients were worried and concerned about their physicians to the point where they actually altered how they conducted themselves in order to avoid further overwhelming or stressing out physicians that they interpreted as being unwell. Finally, patients appear to have quite a nuanced understanding about how physicians' work can put them at risk of being unwell, indicating that an understanding from patients that there are wellness costs to physicians. They are human beings. It's quite a demanding job. It's a very privileged job, but it does come with some risks and some challenges that make it difficult to care for themselves and be their best. And patients recognize some of those costs. It's important then for physicians to be well, but it really does raise the question as to where that burden of maintaining physician wellness lies. We didn't hear any patients blaming physicians for not taking care of themselves or being well. It was really framed as concern around or a recognition that can sometimes be challenging for patients. And it really gave the impression that patients may be a really strong ally in helping support more system level interventions, that it's not solely the responsibility of a physician to maintain their own wellness, but that there can be system level supports to make it easier for physicians to access resources that help support their wellness. Maybe some system changes in terms of some of those expectations that are placed on physicians that make it easier for physicians to be well and take care of themselves. And we've seen a shift of that in the literature. So what we heard from the patients is really quite in line with the direction of the physician wellness literature, where initially there was a focus on how individuals can look after their own wellness, but there's become a greater awareness over recent years that while that's important and necessary, it's also not sufficient. We need to also consider how the system can be adjusted and how it can help support physicians in taking care of themselves and setting them up for success in that area, as opposed to making it more challenging for them and more demanding. And so patients are really recognizing that as well, which is quite encouraging. There's a few limitations that I just wanted to highlight in terms of how our results can be interpreted within our study design. It really was an exploratory study. Nothing had been done in this area before, so there were no hypotheses that we could go in and test quantitatively. It really was designed to generate hypotheses and really just deepen our understanding around the topic and how patients may be involved in this space, because they hadn't been considered previously. Because of that, we really did focus on a limited sample. We sampled patients from a single urban center here in just in Calgary. We didn't go broader than that. And our sample included a large proportion of retired older adults with relatively frequent interactions with the healthcare system. So we get quite a rich understanding of their experiences and their perceptions, their views, but we don't quite know how that represents patients more broadly. So, for example, we don't know for sure if these same types of premises would be identified in a more pediatric population, for example, or even a younger adult population. We did speak with a couple of younger adults. 25 was our youngest, but overall our average age was near 60. And so definitely some unknown, I guess, around how perceptions may vary across the age spectrum. We also recruited participants from outpatient settings, and most of the examples really did reflect that outpatient experience. Patients' views of physician wellness, I think, are very reflective of that outpatient care setting, but it's possible that patients hold different views about physician wellness in acute care settings, where there's less developed relationships perhaps between the patient and the physician, and where physicians need to deliver more complex or more urgent care. For example, actually a few patients even acknowledged that they may have different perceptions if they were going in for surgery, perhaps, than they might when they're sitting in their family doctor's office in the community. And so we weren't able to tease apart those differences in this study. We really did delve more into that outpatient setting with the examples that we heard about from patients. That leads us then to a few future directions that we think are really worth exploring and talking about, and we can chat briefly about this during the discussion period today if you'd like, around some of the additional avenues for research to really extend this work and learn about it more broadly. One of them is we are starting to look at a patient survey to enhance the generalizability of our findings and determine if those views are echoed by others. So considering a broader care setting context, a broader range of geographic locations, ages, education statuses, employment status, all of those kinds of factors. We just want to get a broader sample. We want to test quantitatively some of those hypotheses to understand better those relationships, especially some of those bidirectional relationships between patient care and physician wellness. And we want to also consider some of those other groups. So both in terms of that pediatric patient population. Do they also notice cues about their physicians? And how do they make judgments around that? How do they interpret the care that they're receiving? How do they feel in that encounter with their physician? Are they also altering how they behave? Do they become less trusting of a physician that they somehow perceive to be unwell? All of those questions are kind of unanswered. Unfortunately, we don't have the data to analyze that in this current study, but I think it's definitely an important avenue for future investigation. I think it would be quite interesting to see. I think kids probably perceive a lot that we may not even realize, and so I think kind of delving into what they're noticing and how they understand those things could be quite important for understanding the care relationships in that population. We also focus specifically on physicians, but of course, there's probably, I would hazard a guess that there's quite a bit of overlap with other providers as well. For example, nurses, pharmacists, dietitians, social workers, occupational therapists, physiotherapists, psychologists. I imagine that if we asked patients about visiting any of these providers, there'd be some similarities in terms of some of those cues that they're picking up on and how they think it's perceiving their care. So I think there's quite a potential to explore those care relationships more broadly as well in that space. So I'd like to just, turn it over. Our contact information is here, both for myself and the principal investigator on the project, Dr. Jane Lemaire. But I think I'd like to turn it over for some discussion and questions now. I'm happy to address any questions you had, or to talk even a little about perhaps some of your views on whether this could apply or not to other providers or to the pediatric population. So thank you.
All right. Thank you very much. I mean, really an interesting presentation in that I think it's the subtlety of the impact on care is, I mean, it sort of seems sort of simplistic at first, but when you start putting it together as, people don't follow their care plans as well, or don't talk about the things that are important, or that may very well be important when they go to the doctor's visit because they're concerned about it. I mean, there's some very serious opportunities to impact the patient's healthcare here. So it's quite an interesting study. One of the first questions that came up was just a request for a link to the article that you mentioned, the publication that you mentioned at the very beginning of the presentation. If you have a link to that you can either share with us now, or if you can just share it with me after the fact, we can put it on the Knowledge Exchange Network where we post the recording for this and people can have access to it, because there's a couple requests for that article.
I'd be happy to do that. I can send that to you afterwards, and it is publicly accessible. It's open access. So.
Yeah. All right, great. So one of the questions I had was, and you may have said this at the beginning when you were talking about sort of who was involved in the study. Were all of the physicians essentially general practitioners in the community setting, like GPs, family physicians?
So we didn't specifically sample physicians. We sampled patients, but most of the examples that they gave us in the interviews really did clearly focus on, family physicians or those community care providers. We didn't limit it to that, so they could have told us about any example that they had encountered or anything that they had heard about. A few people did allude to the idea that surgeons, for example, it might be slightly different, but the examples by and large were focused on that kind of GP, family physician in the community.
Mm-hmm.
Yeah.
And you either speculate, or I'm assuming this probably wasn't covered in the study, but I'm curious as to whether it would be different because one of the examples I think you mentioned early on was, a lot of it was around weight, obviously, as sort of the indication of wellness. If you were seeing this practitioner at some point in your life, and then you didn't see them for a while and came back 6 months, a year later, 2 years later, and they had suddenly put on 100 pounds, I think was part of the quote, that there was a concern there, and there was there was this reaction from the patient about, their perception of their wellness and their ability to care. Would it be different if your initial reaction or your initial encounter with the physician or any practitioner where the physician was already that way, was already, obese in some way, as opposed to that change, like going from someone who was maybe not obese to gaining that weight. Do you think it would be different in that if your initial encounter was positive with the physician and they were already potentially, had signs of unwellness or related to obesity or something like that, versus that change that you might have seen over the course of your interactions with this practitioner?
Yeah, I think that's a really good question, and I think it's somewhat complex. So one of the things that we realized from the data was that it was harder, it was somewhat challenging for patients to notice signs of wellness or unwellness. It was much easier for them to describe. So one of the questions asked them to describe signs that they might notice. It was much easier for them to pick up negatives than it was for them to identify positive aspects of wellness. So we heard a lot about stress, being unkempt, looking really tired, yawning, coughing. Those kinds of things were much easier for patients, to pick up on. And some of those things could easily be observed in a first encounter with someone. So even if they hadn't seen a physician before, some of them were picking up on some of those cues, especially the more obvious, easily observable ones. So things like weight, for example. Or if someone came in limping, that's a really clear example. Those kinds of things patients would pick up on almost immediately, it seemed. And so they could color even that first interaction with them, and it could have an impact. The more interesting, perhaps, side of it is really in that relationship. So a lot of the patients told us about how important that relationship was, and that if they knew a physician over time, it made it easier for them to understand if they were well or unwell. And I think it allowed them to pick up on less observable indications of that. So one could be the weight in terms of noticing weight changes, but I think even more important was more subtle or less observable changes in things like mental health. I think in many cases, they talked about it being challenging to identify those in a single encounter, but that those over time really became much more evident. They could pick up on subtle shifts in personality or just that more tension that they wouldn't have picked up on in a first encounter. So it's quite a kind of a complex thing. I think two different things are happening there, where in a first encounter, they're potentially picking up some of those easily observable cues, and over time they're picking up some of the more challenging cues to observe. We did also hear a few examples from people saying in and of itself, things like weight wouldn't impact them if a physician seemed well otherwise and they had a positive first encounter with them, that wouldn't impact, whether they follow their instructions, whether they go back and see them again. So it wasn't there's definitely, as you alluded to, there's definitely that element where even if they are kind of potentially unwell in some capacity, weight being one of the key things that was potentially mentioned in that space, that it wouldn't necessarily color future interactions, and they'd still be willing to see them as long as they seemed well outside of that. So.
As you were answering, giving that answer and sort of shifted to the mental wellness as opposed to the physical wellness, or in addition to, someone was asking a question just before that about commenting on patients' views on mental health of physicians and or any comments they might have made about the mental impact of working in a healthcare environment on the physician. Is there anything else you'd like to add? In fact, I think you had a specific comment or quote from one of the study subjects about their perception of the impact of working in healthcare. Could you maybe just refresh on that?
Yeah, so definitely it was harder for patients to notice those mental or emotional signs of unwellness. It was easier, as I mentioned, over time, and they did definitely acknowledge the challenges of working in the healthcare system. They talked about just the sheer stress of the expectations, the long work hours, the lack of resources. And so there was quite an indication of impact on mental health. I think it was harder for people to pinpoint when they were struggling with mental health issues, just because it is less observable. It's not like walking in on crutches with a broken leg, for example. But they definitely did have acknowledgement that it took a toll and had an emotional cost caring for patients all of the time with some of the difficult cases that they see, patients that they're unable to help and subsequently may die. Definitely some trying emotional experiences within healthcare, and the patients did recognize that.
All right. Now this, I think we're at the point now where we're going to be asking you to completely speculate, as we have a few questions about providers other than physicians. But the question is, how do you think that patients would perceive the impact of clinician wellness for nurses and or other allied health professionals was the question. But I'm wondering, again, probably very likely pure speculation at this point, but the historic sort of attitude or opinion or the way that society has elevated physicians above other providers historically, that certainly has changed over time. But there was always a perception of physicians at a different level than other providers. Do you think there would be more acceptance of signs of unwellness in other providers that would not have as great or as significant of an impact on the perception of the patient to think that they can do their job, sort of thing? Or do you think it would be different? Like, can you speculate at all on that?
Yeah. So, I mean, my sense, and this isn't, obviously we don't have the data, so this really is my speculation, but my sense is that we would see a lot of similarity. The patients told us loud and clear, we put physicians on this pedestal, there's high expectations, but ultimately at the end of the day, they're human just like the rest of us. There was a lot of comparison to professions such as bus drivers, even pilots, those other professions where, just like my bus driver needs to take care of himself to ensure that he gets me safely to and from where I need to go, I also want my physician to take care of themselves so that they can do their job to the best of their ability. So we heard loud and clear that the patients really did see them as humans first and foremost. They just happen to be in this important role, and that they're no different. How they need to take care of their wellness is just like everybody else. We need to follow, we need to eat well, we need to get some exercise, we need to get some rest, all of those factors that apply kind of across the board to any person, regardless of their occupation. And so I think in many ways we'd hear very similar stories, very similar views. My sense is that patients would pick up cues in a nurse or a pharmacist, any other provider, as you may if you encounter one of your colleagues at work. There's some universal things that we pick up on when we see someone even walking down the street that perhaps we never met. You can sometimes get a sense of if they're in trouble or if they are doing well. And so I think those similar types of cues would get picked up in other providers. And my sense is that there would be similar reactions to those responses and similar expectations that they would care for themselves as well. There may be some nuances. I mean, doctors are in a somewhat unique role in terms of the demands that are put on them, even within the healthcare system. And so there may be some nuances in what that looks like. I think doctors perhaps have a higher there may be higher implications if they miss an error, like make an error, for example, than perhaps some of the other healthcare providers. That's not always going to be the case, but I think there could be cases where it's a little more life and death, for example. So potentially higher stakes that may change things a little bit, but I think by and large we'd find similar patterns and results across any provider. But again, that's just my sense of it because we haven't actually delved into that.
All right. Thank you very much for that answer. The person who asked it said that's exactly where she was going with the question. So
perfect.
This last question, we're pretty much through the questions that have come in. So if there is anyone out there who is rapidly trying to squeeze one more question, we'll certainly be happy to take it. But there is one more here that I wanted to inject. The question started with a comment just saying this is a very interesting and important study, especially, she says, the final key message. This is when you were going through the key messages at the end. She said the final key message is about how patients can be an important ally in physician wellness. So that sort of Yeah, it's almost like we always talk about family-centered care, but it's more, it's an interesting concept of the partnership between patients and families to support each other. I think that really struck a chord with some in the audience.
That's great. Yeah.
So with that, I don't see any other questions coming in. Is there any closing messages you'd like to leave the audience with before we leave, or any comments about future research, where people are going to get more information? That you guys do have your contact information up on the screen right now. But if you is there anything you'd like to close off with before we wrap up?
Sure. Well, I'd like to just thank you for the opportunity to share today. We've been quite excited about this work. It is really on the leading edge of where things are going in the physician wellness space. And I think over the next few years, we're going to see a lot of that additional work coming out in terms of looking at some of those broader questions that we've just kind of been speculating on with regard to pediatric populations, different kinds of providers, different care settings. I know our team is going to be undertaking a more quantitative study with a broader sample to try delve into this again a little deeper, try get a better understanding of what's going on. So I do think that this study can be a bit of I'm not even sure what the right word is, but I think it can spur on some additional research in this area, and I think it's going to lead the way in a few more studies that really help us understand better what that patient perspective is and how they can partner with physicians to make the system even better. Because ultimately, if providers are well, they can provide better care to patients. And so it really is important to support them. And I think that in addition to what our team is doing, I think we'll start seeing some other work in this area coming out soon. I'll be happy to share that link after the fact so people can read the official paper if they're interested. There is more detail provided in there, of course, around the study and some other considerations, more examples of what we heard in the data that really kind of help flesh out what we were seeing there. So I would encourage anybody as well, if they have any questions after the fact, to feel free to reach out. We'd be happy to chat about it further. But thank you again for everyone who tuned in and is watching and for the opportunity to join you today.
All right. Well, thank you again for a great presentation. I mean, it really was a thought-provoking, topic, and as you can see from the conversation, and as you said, the opportunities to extend this research to other populations, I think, is obvious, and we hope to see that sometime soon. So hopefully, you'll be in touch when you do complete that in the next couple of years.
For sure.
All right. Thanks again. And we do our webinars every Wednesday at 11 a.m. Eastern Time. And it's great when you do get to watch live, as those questions and comments really enrich the discussion. But when you can't watch live, we do record these sessions and make them available after the fact on the Knowledge Exchange Network at ken.childrenshealthcarecanada.ca. The recordings are up usually within a day or two. And as we mentioned, the link to the article will also be included in there. Our next webinar will be on February 27th, and we're excited to bring a very special presentation titled Caring for Rare, Canada's National Strategy. And February 27th is the day before Rare Diseases Day, which is February 28th. But on February 27th, we will be hearing from Dr. Durhane Wong-Rieger, who many of you probably know with the Canadian Association for Rare Diseases, and she has presented at our conference in the past, and she's done webinars in the past. But she's actually going to be sharing with us the vision for and how far along we've gotten towards realizing a national and even a global strategy for rare diseases. And in fact, Dr. Wong-Rieger is following the webinar going to be flying off to Geneva with the World Health Organization to be signing some declarations around rare diseases. So some exciting stuff for those of you who work in the area of rare diseases and rare disorders coming up next week on February 27th. So thanks again for joining us today, and hopefully we'll see everyone back here next week. All right, bye everyone.